When an individual is diagnosed with bone metastases, we continue to use prostate cancer-directed therapy. So we just consider that this is progression of disease, and we make sure that whatever treatment we're using for the prostate cancer is the right one. If we need to change therapies in order to readdress this continued growth, then we will. That's the most important thing, that we want to make sure that someone's on an effective therapy, and sometimes if one develops new bone mets, that would be indicating that the therapy is no longer effective and we need to change treatments. Specifically, to address the bone metastases and reduce the risk of complications from the spread of prostate cancer into the bone, we use medicines that strengthen the bone, like bisphosphonates or zoledronic acid or Zometa, most commonly, or denosumab, also called Xgeva. And these medicines strengthen the bone, but they also do a very important thing. They prevent something called skeletal-related events. When a man has prostate cancer in his bones, he's at much higher risk of developing something called a skeletal-related event. These include things, as you would expect, like fracture, but they also include cord compression, which is when the prostate cancer pushes on the spinal nerves and makes men have weakness in their legs or in their arms, numbness and tingling, and eventually, if we don't address it, it can cause paralysis and incontinence or the loss of the ability to control your bowels or to control your bladder. And it's a side effect or a complication of prostate cancer that we never want to have happen. So that these medications prevent that or reduce the risk of that. They also reduce the need for surgery to stabilize bone or the need for radiation to treat pain in the bone from the areas of prostate cancer in the bone. So they address 4 things, these skeletal-related events: fracture, cord compression, and the need for surgery and radiation to bone.